right, welcome back everybody. Looking forward to another great lecture and have the great pleasure of welcoming Dr. David Nathan. He is going to talk to us about diabetes, an update for the subspecialist. He is a professor of medicine at Harvard Medical School. He's the founder of the Diabetes Center and directs the Clinical Research Center at Mass General Hospital in Boston. He's internationally acclaimed as a diabetes expert, and we're fortunate to have him here today. Dr. Nathan, go right ahead.
Thank you very much. Yeah, you're especially fortunate because I was at 6 this morning. I was shoveling out my driveway. So I'm waiting for when AI can take care of that. So far, it's just me shoveling. Anyway, it's great to see you all here in person, and to those of you online, welcome as well. So I'm going to talk about diabetes, an update for subspecialists. I have one duality of interest in my entire 50 years of research. I did consult once recently for a pharmaceutical company. Today we're going to talk about specifically how diabetes intersects with basically everything. We'll talk about inpatient care and outpatient care. To begin with, I'm going to talk about really diabetes as I do to any endocrine or internal medicine program, just kind of a background to think about how, the origin of diabetes, mostly type 2 diabetes. We'll be talking about the epidemic form for the most part today and not type 1, but just how it intersects with virtually everything that anyone does in medicine. And the reason is this. I mean, firstly, it's one of the most common diseases we have, certainly the most common chronic disease on the planet. In the US, the latest statistics show that about 40 million people have it, with 12% of the adult population. If you look at people who are older, basically 1 out of every 3 people over the age of 65 has diabetes. So, I mean, you all know this is a pandemic. Type 1 remains relatively rare, and again, I'll be talking about that occasionally during this talk, but mostly focusing on type 2 diabetes. And of the type 2 diabetic patients, of the 38 million or so of type 2 in the country, about 9 million of them remain undiagnosed. So they're just walking around with diabetes, don't know it, and therefore can't get, aren't being treated for their hyperglycemia, aren't getting special attention for their hypertension, their other cardiovascular risks. Gestational diabetes is rather stable, and then prediabetes, which think of it as a prep school for type 2 diabetes. These are the folks who are at exceedingly high risk, usually by virtue of being overweight or obese, and they have glucose levels that are starting to rise, but not high enough to be considered diabetic. That's 115 million people. So, a huge fraction of the population. If you count the diabetic population and the pre-diabetic together, 155 million people in the US, with a population less than 400, I mean, it's a lot of folks. And so it intersects with everything we do. As you know, the complications of diabetes is what often brings it to the attention of subspecialists. It's the most common cause of end-stage renal disease in adults in the world, most common cause of blindness, most common cause of amputations, and it increases the risk for non-specific cardiovascular disease by 2 to 5-fold. The cost of it in the US each year is $400 billion to take care of the diabetes as well as its complications. Okay, a moment to talk about the pathogenesis, because that's going to kind of get us towards when we think about prevention and treatment. So as you all know, this is a 2-hit, for something that's this chronic, this common rather, to have 2 major deficits underlie, not 1, but 2 deficits intersect to cause this. So the first thing is that based on, for the most part, age, obesity, sedentary lifestyle, a number of medications that are commonly used, people develop insulin resistance. They don't get the same glucose lowering effect for a given amount of insulin that they make. And that leads to slight rises in glucose, impaired glucose tolerance. But the second hit is that in that setting, if you make tons of insulin, if you're capable of making insulin till the cows come home, okay, then you don't get diabetes. On the other hand, if you have decreased insulin secretion, which can be genetically mediated, it may be premature infants, for example, whose pancreases maybe don't develop as much as full-term infants, make less insulin, and the combination of resistance and decreased secretion leads to glycemia that is rising, fasting hyperglycemia. And in turn, there's a secondary effect that as glucose levels start rising, it further impairs both resistance and increases resistance and further impairs secretion. And so you end up with diabetes, and with diabetes over time, you get the chronic complications, mediated for the most part by the elevated glucose levels. Okay, let's talk about prevention for a few moments at least. I mean, this is this huge epidemic. It would be best to nip it in the bud. The prevention methods largely address those identified modifiable risk factors. Age is not modifiable, as far as I understand. Obesity and sedentary lifestyle, on the other hand, are modifiable, and I'll show you examples of how modifying them help. So what is, firstly, the relationship between overweight and obesity and diabetes? Because that, in fact, is what the epidemic is all about. We are better fed, overfed, for the last several decades, at least 50 years probably. Obesity and overweight have skyrocketed, and in parallel, diabetes has gone up. This is a study from the Nurses' Health Study, and it was a magnificent study. It's 30 years ago or something. This showed the relationship between body mass index on the x-axis and over the next 14 years, the risk of developing diabetes. And you see this sharp rise. As BMIs at baseline rose, the risk of diabetes goes up about 100-fold. By the time you get a BMI greater than 35, greater than 40 is considered severe obesity, your risk is about 100-fold more than if your BMI is 22 or 23. 100-fold. That kind of risk function you don't see in any other chronic disease, okay? This is the problem. In the 1990, overweight was 32%, obesity was 15%. Severe obesity, 1%, a BMI greater than 40. 2015, it's gone up by double, triple, and as you know, the rate of diabetes went up double or triple. 2023 now, obesity has leveled out a little bit, but severe obesity has now gone up to 10%. And this is where the risk is 100-fold higher than someone who's thin. So this is the source of it all. Complications of diabetes, cross-cutting across every specialty you can imagine. It's the complications, the specific complications affecting retinopathy, the eye, nephropathy, the kidney, neuropathy, the nervous system, are a combination of glycemic exposure. And then in addition, other non-specific, although related to obesity, think about it, hypertension, lipids, and smoking also cause these complications to increase. The outpatient and inpatient management of diabetes interfaces with virtually every area of medical care, as you can see by this body, which has complications all over. So, for example, cardiovascular, peripheral vascular disease, they get a lot of cardiovascular disease. They got a lot of foot wounds from both peripheral angiopathy and peripheral neuropathy. Renal disease, CKD, neurology, peripheral and autonomic neuropathy, anesthesiology, perioperative management, oncology, nutrition, chemotherapy, steroids, rheumatology, I mean, on and on and on. There isn't a subspecialty that isn't affected, or a specialty of medicine. Obstetrics, pregnancy, gestational diabetes, GI, maldigestion, nutritional issues, diets, okay? Infectious diseases, increased risk for infections, overall, and then surgery management, ophthalmology, etc. Okay, so that's the background, quickly. Let's talk about specific topics. I said I'd talk about prevention, at least briefly. Primary prevention, meaning taking people who are at high risk, pre-diabetes, again, rising glucose, but not high enough to be considered diabetes yet. There are a number of studies. The one I'll talk about mostly is the Diabetes Prevention Program, which I've had the privilege of leading for the last 30 years or so. It's a US study. And this is what we did in the Diabetes Prevention Program. We looked at the modifiable risk factors, basically lifestyle risk factors, trying to reduce overweight and obesity, increase physical activities. So we had an intensive lifestyle program that was aimed at achieving a modest 7% loss of body mass, okay? And also increasing their activity level. And we did this in a high-risk population with prediabetes. We also had a second arm or a third arm other than the placebo, which was metformin. Metformin is the most commonly used medication on the planet. That's it. More people use metformin than any other drug on the planet. It's inexpensive and used to treat diabetes. Here, we were trying to use it to prevent diabetes. This shows the weight change that we got in these groups. Metformin, it turns out, in the yellow line, is a pretty good weight loss drug. This is over 4 years, and they lost about, 2-3 kilograms just by taking metformin. Nothing else changed. The lifestyle intervention, as you see, we were aiming for a weight loss goal of 7%, and at 6 and 12 months, we exceeded that, 7.2%, and then the weight went up. We were grown-ups. We knew that this would happen, that they regained some of the weight, but even at 4 years, they were still down by about 4% from their initial body mass. Their activity levels, mostly walking. We told them to walk, and we asked them to walk about 30 minutes a day for 5 days a week. That was it. And that was the goal, 150 minutes a week. In fact, they did more like 220 minutes a week. They were out walking in the malls, they were walking to the supermarket, they walked. And even by the end of the study, they were at 190 minutes per week. The results of the study were pretty remarkable. Okay, the lifestyle group had a 58%. We could cut down that diabetes, the new development of diabetes from this huge number by half. And the metformin reduced it by 31%. We have we stopped the program after an average of about 3 years. Okay, it went as long as about 4 years to 5 years. But after 3 years, we stopped it. But then we continued to follow the population. And they no longer got the intensive therapy they were receiving. We did show everyone how to do the lifestyle. We gave them instructions. This is how you reduce your intake. This is how you lose weight. This is how you should walk more. We told them to walk more. So we did that. We also continued the metformin group on metformin, but it was now unmasked. The placebo group stopped placebo, metformin kept taking it, and we have continued to follow this group. And the original interventions, after 10 years, it was 34% for the lifestyle reduction, 18% compared to the original placebo group. After 15 years, 27% reduction, 18% reduction. And our most recent paper, after 21 years, after the end of that initial study, 24% reduction and 17%. So this could actually take a big bite out of the diabetes epidemic if we could do it. There were also other benefits of prevention. You lower the hemoglobin A1C, and people were taking fewer medications, fewer diabetes medications for sure. Lower blood pressure and lipid levels. The fact that we delayed or prevented diabetes in this group, as I showed you, like 24% over 20 plus years, they had fewer complications. They weren't getting eye disease and kidney disease. And then the final thing is that in terms of the cost economics of it, the intensive lifestyle was cost effective, cost some money, but it was considered to be a great investment. Metformin was actually cost savings. There isn't a therapy on the planet which is actually cost savings because they usually cost so much, but metformin is so cheap that it actually was a cost saving, okay, compared to saving the complications, et cetera. CMS, Medicare and Medicaid in the US, approved this, and it is now a funded program. It's called the National or the Medicare Diabetes Prevention Program. Patients on Medicare or Medicaid can get this for free, okay? This is an advertisement for it in Massachusetts a number of years ago. Metformin, or glucophage, as it's sometimes called, has been approved in numerous countries around the world for prevention. In the US, oddly, it has not been labeled for prevention, although people use it all the time, of course, but it has not been labeled by the FDA for prevention. If somebody wants to, I can give them the details on that. Okay, well, that's kind of old-fashioned. I mean, that study ended more than 20 years ago. What about newer things? Well, this is the first time I'll be talking about the GLPs. You've probably read about it in the paper 15 times this morning already, but this is what I'll talk about for prevention. There was a study called the SURMOUNT study using tirzepatide, one of the newer GLPs, a combination of GLP and GIP, gastric inhibitory polypeptide. And here we see that drug, as advertised, we lost 7%. These folks lost about 11 to 15% body mass. So these drugs really work. I mean, they are really quite effective at losing weight and, not surprisingly, reduce the development of diabetes not by the 58% we had with a lifestyle, but over the same period of time by more like 90%. So more weight loss led to more prevention of diabetes. So this is clearly an option. It effectively takes off medications. The little problem here, the estimate of what it would cost in the US to treat people with prediabetes, to prevent diabetes, is 16 trillion, okay? 16 trillion. We talked about diabetes costing 400 billion per year in the US. This would cost 16 trillion. So these drugs are largely, for this kind of use in this large population, unaffordable. They work, they're quite effective, but they are incredibly expensive. Okay, let's turn from prevention to management. That's what most of us are dealing with all the time. In terms of management and standards of care, every organization under the planet has come out with their own list of how to control the risk factors, and mostly risk factors for cardiovascular disease. So A1C targets, generally less than 7%, I'll go into that in a minute, sometimes less than 6.5%, blood pressures, less than 130/80, LDL, largely driven not by the number, but by the risk status that the patient has, okay? So we've moved away from using the number to, if you've got diabetes and you're an older person, you get put on either moderate intensity, if you have no cardiovascular disease and you're older than age 40, or high intensity, which I've defined in the slide. These are all in your slides. By the way, some of the slides have been changed slightly. I update them literally on the week before the lecture. So some of them are a little bit different, but most of them are just the same as you have in your syllabus. But high intensity and moderate intensity, defined by the use of statins generally, and sometimes adding ezetimibe or a PCSK9 inhibitor, depending on the state. You use either moderate or high intensity in people with diabetes, okay? What about, let's get down to the major things. Diabetes is a disorder, a disease of glucose control, okay? So how do we control people? Well, in general, we treat people intensively with some caveats. This is actually one of the few things I'll show you for type 1 diabetes. This is autobiographical. I've been involved in this study since I was a teenager, basically, almost. And what this was in type 1 diabetes, the kind of famous study that showed that if you reduced hemoglobin A1C, on the left you see the intensive group lowered it to 7%, the conventional was 9%, and we had these enormous reductions in all microvascular diseases. Later on, we also showed that we actually reduced cardiovascular disease as well. So intensive therapy lowers retinopathy, nephropathy, neuropathy, and cardiovascular disease just by lowering the A1C. Blood pressure was the same, everything else was the same. So A1C is really at the heart of diabetes-specific complications, okay? We've done long-term follow-up of that study as well, and so we've shown that we reduce actually not just kind of the appearance of retinopathy or GFRs that are falling slightly, but we reduce the development of really bad kidney disease and blindness and amputations and heart disease. And mortality is improved. So intensive therapy is the name of the game. And here are a bunch of studies, the DCCT in type 1 diabetes on the top, and then this whole list of type 2 studies, all of which demonstrated, again, that they could lower kidney disease, eye disease, nerve disease, just by controlling glycemia. And it turns out, you see that the bars are different. Some are reducing by 10%, some by 30%, 40%. It turns out that the A1C difference, again, drove the benefit. The lower the A1C, the fewer complications you got. So there's the A1C differences. Bottom line is that the reduction in diabetes-specific microvascular complications largely is proportional to the A1C reduction, and this is shown in this slide in the yellow line for type 1 diabetes. So this shows the mean A1C over time and the event rate. This happens to be for retinopathy, but I could show you the same graph for nephropathy, for example, okay? The yellow line is type 1 diabetes, 43% reduction for every 10% decrease in A1C. Going from 10 to 9, 9 to 8.1, 8.1 to 7.3. Each one of those decrements will lower your risk by 43%. So even if you don't get to 7%, lower is better. For type 2 diabetes, this is a study from the UK, it was 37% reduction for every 1 percentage point A1C. 10 to 9, 9 to 8, 8 to 7, 7, each one of those lowers your risk by 37%. So again, if your patients can't get their A1C to 7, you say, well, at least get it down by a point. Get it from 10 to 9 or 9 to 8. That will actually benefit them over time. Well, should we get it even lower? 7% is the number that most of you should know is what we're aiming for. It turns out here that if you look at the less than 7%, the curves, they continue to drop, but it's really relatively flat in the less than 7% range. And you just don't get very much in terms of absolute complications less than 7%. Therefore, the risk reduction is smaller. On the other hand, the cost and the risks, like hypoglycemia, as you get less than 7 down to 6.5, down to 6, those increase dramatically. So down here again, the relative benefit is low, the relative risks are higher, so you have diminishing benefits and increased costs. And costs, I mean complications of therapy. So for the most part, we look at 7% as a reasonable goal for most patients. Okay, that's microvascular. What about cardiovascular? What is the relationship here? Cardiovascular, remember, is not diabetes specific. Non-diabetic patients get heart disease also. So, we're talking about now a non-specific benefit. And here there have been a number of studies in type 1, the DCCT, again, showed these enormous reductions. But remember, type 1 diabetes are generally younger people. Their risk factors are mostly glycemia. They don't have a ton of hypertension. They don't have a lot of abnormal lipids compared with the type 2 population. Older patients, more overweight, more blood pressure problems, et cetera. So if we look at the type 2, there have been a number of studies. The benefits are lower, but they're almost all in the right direction. The studies that have been large enough and long enough show a reduction in heart disease by about 20% just by controlling glycemia. This is not blood pressure, not lipids, okay? There's been one study, the ACCORD study that some of you may know, which showed that there was an increase in mortality, which no one still understands. I'll try to explain it a little bit. But that's the one outlier. But in general, so we thought that the mortality effects there had nothing to do with the glucose levels. Then there are the most recent studies, EMPA-REG and LEADER. These are the GLP and the SGLT levels of studies. Note there on the right that the A1C lowering is actually pretty trivial with those particular studies, 0.4%, 0.5%. So our sense is, and from lots of studies that have been done, is that the cardiovascular disease benefits, and I'll talk about this a little later in more detail, of the GLP drugs and the SGLT2 inhibitors are extraglycemic. They have to do with other benefits of the drug, like, for example, lowering weight with the GLPs, which we already talked about. So they're probably extraglycemic. So the rationale for lowering A1C to less than 7% is largely related to the demonstrated lowering the risk of microvascular complications, eye disease, kidney disease, nerve disease, but probably macrovascular disease as well. Almost all of the studies except that one showed a benefit. The one exception, the ACCORD study, actually aimed for an A1C not less than 7, not less than 6.5, but less than 6. And they used between 3 and 5 diabetes medications to get there. So, it got really complicated. And we just don't think that ACCORD study actually rules out in any way the recommendation to get A1Cs less than 7% for all of it, okay? So A1C lowers microvascular risk and almost certainly macrovascular risk. Getting your A1C less than 7 to, for example, less than 6.5 doesn't seem to be an appropriate choice because of the increased risk. There is support, as I said, for CVD, lots of studies. No support for an A1C less than 6.5 in type 2 diabetes, and there may even be harm, as was shown in the ACCORD study, which wanted to get an A1C of 6%. So again, an A1C less than 7 is justifiable for many or most patients at this time. However, keep in mind, if you have a 92-year-old person who comes in your office, lowering their A1C, this is a chronic disease with chronic complications, is not going to extend their life by 1 second. Okay, I mean, you know, again, if their age is limiting their ability to prevent chronic complications, you have to think about it. So you need to individualize all of these goals based on age, expected survival, comorbidities, and the risks of the therapies. Okay, but you all know that. All right. How do we do this? What medications do we use to treat diabetes? Well, in the first 73 years after the introduction of insulin therapy in 1922-23, there were 3 sets of drugs: insulin, sulfonylureas, and the biguanides, that's metformin, okay? Until about 1995 or so. Since 1995, in the last 27 years or so, the number of classes has tripled. So there are now like 9 classes of drugs, and you know, each one of them has a half a dozen medication examples within it. So it's gotten much more complicated. A major reason to lower glycemia, as I mentioned, is to prevent disease, complications, okay? In addition, if you have already some established disease, some of the more recently introduced drugs actually have an additional benefit. The GLPs for heart disease and kidney disease, SGLT2s also for heart disease and kidney disease. So again, lowering glycemia in general, but then thinking about specific drugs if you already have complications. This is the ADA standards of care. You know, it is incredibly complicated. You need a magnifying glass to read it all, but the bottom line is that, again, what it directs is that for step 1, you phenotype your patient, and if they already have heart disease, that drives you in a direction to use a specific drug which has been demonstrated to help with heart disease, like a GLP. Okay? If you don't have that, you know, then you try to lower blood sugar and weight goals, et cetera. So it depends on what the patient looks like, but this is kind of horse out of the barn therapy. They've already developed their complication, now you're going to try to ameliorate it or mitigate it. For most people who haven't, a lot of people get heart disease, but most people with type 2 don't have it, and you should treat them to lower their glycemia safely and manage all of their risk factors. I'm going to go back to something, so I'm going back to it because I helped lead it, and this is from not quite 20 years ago, but a long time ago. This was the first iteration of a consensus algorithm, and the reason I'm going to use it is because it's so much simpler, I think, to understand, and it captures all of the details, I think, that the more complicated one does, and it's easier for teaching purposes. So the reason that we selected the interventions that we did for that initial one was, firstly, we knew that lowering glycemia was important, as I've already talked to you about. So choosing medications and combinations of medications that lowered glycemia was the #1 thing to do. If your A1C started quite high, you may need a more powerful medication, like insulin, initially, okay? If on the other hand it was close to where you wanted, then you had much more latitude to choose a medication. We thought about safety, side effects, other characteristics, and we thought about cost. Okay, that was part of this original algorithm. This is the hierarchy of glycemia lowering of the medications. I don't know how many classes I have. 9 there, 3, 4, 5, 6, 7, 8. Yeah, 9. Okay, there they are. There's the 9 classes of medications. Insulin's the most powerful. Metformin, sulfonylurea, TZDs are hardly used anymore, and then GLP agonists are kind of a little less powerful, et cetera. The one exception to this is tirzepatide. This latest GLP, which is a combination GLP plus GIP, is actually almost as powerful as insulin. I mean, it's a game changer. It really is quite potent, and we have to keep that in mind. All right, how do these drugs work? At the very beginning, we talked about the 2-hit effect of insulin sensitivity and resistance, and not surprisingly, these drugs do one of 2 things. They increase insulin supply by either giving insulin or causing your pancreas to make more insulin, or they reduce demand. Okay? Some of them have different effects. They actually affect the absorption of glucose, carbohydrates from the gut. And they almost all, without exception, have a lot of GI side effects, making them sometimes intolerable, okay? And then finally, the GLPs, one of the newer classes of drugs, does both. That's why tirzepatide is so powerful. Not only does it improve insulin secretion, that's how it was originally discovered by my colleague Joel Habner We did these studies, I did the initial studies back in the late 80s, showing that it increased insulin secretion. That's how it was originally developed. But of course, it's also incredibly effective at lowering weight, so it decreases demand. That's why these drugs are really kind of attractive. The latest class of drugs, the SGLT2 inhibitors, turn diabetes on its head. For those of you who are old like me, having sugar in your urine was a bad thing. It meant that the glucose in the blood was high enough so that you were spilling it in the urine. This turns it around. It actually, in a sense, I don't want to say it poisons the tubules, but it affects the tubules so they don't absorb the glucose, and you put out glucose in your urine. And that's how it lowers glucose, okay? The algorithm that we came up with way back when, which is still totally useful, is that with sequential therapy. And step one is you look at lowering, approaching the diabetes by trying to get people to lose weight, increase their activity level. So lifestyle effect, plus very early on, if you have diabetes, you add metformin because it works so well, and it's so inexpensive, and it's so safe, and it's so well tolerated. And that is still, metformin is still the backbone of diabetes therapy, okay? It's what we use. Lifestyle and diet and exercise, which we have as kind of step number one, it's, it can be incredibly effective in the short term, but of course we wouldn't have this problem with obesity and overweight if it worked long term. People would lose weight and keep it off. That's not the case. So it's effective in the short term, but over time, being what we are, I guess, we go back to eating too much and keeping the weight up. But if you do get people to lose 5 to 10 pounds, it's incredibly effective, okay? And this shows a behavioral intervention. Here you see one of the studies called the Look Ahead study in diabetes. They had them on a lifestyle intervention, like I showed you in the diabetes prevention program, but now it's in patients with diabetes. They lose the weight, and their A1Cs drop down to less than 7%. They need fewer medications, and over time, their A1Cs stay less than 7%, okay? So the reason we add metformin, as I said, is because it's so inexpensive, and it's so effective, and it's so well tolerated. And we used to be really cautious about it in people with kidney failure. Nowadays, we use it in people with a GFR down to as low as 45 because it's safe. So metformin, again, is that building block. Everything else we add on top of metformin. And this is what happens. If your A1C doesn't drop with lifestyle and metformin, then you go to the next step. And the next step could be to add insulin. If your A1C is still at 9%, well, then you need to add a powerful medication like insulin. But there are lots of other choices. If it remains high even after adding insulin, now you're talking about somebody who really probably has a good degree of insulin deficiency, and you start treating them more like a type 1 diabetic patient. They not only get a single dose of, let's say, glargine insulin, but now you start adding insulin, let's say, before dinner time, when they have the biggest meal and when their glucose levels rise. But there are other choices as well, okay? And the other choices include using, it used to be pioglitazone, the TZDs, but that's pretty much fallen out of favor because of its side effects. But we go to GLPs. Again, negative is that they cost so much and they cause GI side effects in a good 20% of people. At the end of a year, as you probably know, half the people who started their GLP have stopped it because of either GI side effects or its expense or both. So again, but these are quite useful medications. It's one of the ways to go. And then there are other choices here as well. GLPs, so I mentioned them already for prevention. Unless you're living in a cave away from civilization, if you don't read about these every day of your life, then you're just not reading them. So these are, what do I have here? 6 papers in the last 5 months in the New England Journal on major studies in GLP in the last 5 or 6 months. So this has become a dominant drug for good reasons. The approved indications I have here, it's in your slides again, type 2 diabetes to manage glycemia. Also weight management, cardiovascular interventions, fatty liver disease, chronic kidney disease. If you're obese but non-diabetic, if you have cardiovascular disease, it's approved. Obstructive sleep apnea, overweight with comorbidity, cardiovascular interventions also, okay? Other not yet approved indications, but I can promise that they are being presented to the FDA, are for a whole variety of things. PCOS, addiction. I mean, there isn't a thing on the planet that these drugs have not been approved for, including improving a faltering economy. Specifically, the entire economy of Denmark was based on semaglutide, Ozempic, those drugs, okay? I mean, truly, this has been a game changer in terms of the economics of Denmark anyway. And by the way, when Lilly came out with tirzepatide, Denmark's economy took a hit, okay? We should be discerning when we use these drugs. They are very expensive. As I said, the GI side effects results in half the people taking them stopping them. Okay, DPP-4 inhibitors. I'm not going to go through this in any detail. DPP-4 inhibitors decrease the breakdown of endogenous GLP. We all make GLP, by the way. We make it all in our gut, and DPP-4 enzyme breaks it down. So if you inhibit the DPP-4, the dipeptidyl peptidase, and you inhibit it, it increases endogenous GLP levels. The problem is that they're quite weak. GLP levels go up by 10 or 20% compared to giving a GLP where you raise it dramatically. Okay, GLPs and DPP-4 inhibitors. GLPs, as you know, have been demonstrated, as I've mentioned before, as effective for heart disease, but not all of them. So here I have a list of those that have been shown to be effective: liraglutide, semaglutide, including the oral form, dulaglutide, but some of the other ones have not been shown to be effective. DPP-4 inhibitors, which, as I said, increase your endogenous GLP levels only slightly, well, maybe not surprisingly, have not been shown to benefit heart disease. Okay, as I said, tirzepatide is the most recent one. It is the most powerful. There will be a half dozen other that are under development that we will see pretty soon, okay? But this is an example of tirzepatide compared with glargine insulin. The A1C lowering is about the same. The difference between insulin and tirzepatide is that the weight went up a little, just a little bit, but it went up 4 or 5 pounds in the insulin-treated patients, and it went down in the tirzepatide-treated patients. This is the big deal. On the other hand, look at diarrhea and nausea. Everybody gets a little diarrhea and nausea occasionally, but look at the tirzepatide group. 20% were developing these side effects, plus at a cost of, how many $1 trillion did I say? I mean, a lot of, okay. Severe hypoglycemia, interestingly, was infrequent in both groups. Okay, SGLT2 inhibitors, we've talked about this a little bit. They lower A1C pretty weakly. Their effect is, as I noted, they essentially poison a little bit not in a bad way, I shouldn't use that word. They affect the kidney tubule and decrease the proximal reabsorption of glucose that usually goes on. Therefore, glucose goes whooshing through the tubules and gets excreted in the urine. It causes glycosuria, okay, which has effects in terms of caloric loss, lowers glucose levels. It also gives increased vaginitis and balanitis in men because the GU tract is now exposed to tonically high levels of glucose levels, okay? They have benefits, CVD and CKD benefits with some of them, actually most of them, empagliflozin, canagliflozin, dapagliflozin, and they also help out because they're essentially a bit of a diuretic in people with heart failure. They're kind of an osmotic diuretic, so they help with heart failure. Okay. I'm going to take the last, 10 minutes or so to talk about some special cases. The first is inpatient management with diabetes. We did a study a number of years ago at MGH, and it turns out that 20% of our MGH inpatients, not surprisingly, heart disease, vascular disease, all kinds of stuff, had the diagnosis of diabetes. And we did A1Cs on everyone in the emergency room, and it turns out there were another 10% that had diabetes based on their hemoglobin A1C level and didn't know it. So we're talking about not quite a third of inpatients having diabetes. Their average stay is longer and they are more complicated. And as you know, when they're in the hospital, even if they were doing a good job at home with their diets and their testing, whatever, now they've been taken away from self-care. Diabetes is very much a self-care disease. Everything is different. Meals are different, diet is different, schedule is different, medications are different. So treating people in the inpatient setting is difficult. how should we aim for diabetes care in that short period of time when they're in the hospital? We've talked about their outpatient care, aiming for an A1C less than 7% for the most part, et cetera. But how do we treat them in the inpatient side? The first thing is that we want to avoid large fluctuations in blood sugar because they will lead to hypoglycemia potentially, but also if they're hyperglycemic, dehydration, symptomatic stuff we don't want. You never, of course, stop insulin in a type 1 diabetic patient because they'll go into DKA, so you never do that. In type 2, we often stop their oral agents and for ease of management, treat them with insulin because it's safer, we know the effects are, and we take control of their diabetes care anyway. You want to make sure you protect their feet. Every day when I see our diabetic patients, I check the heels of their feet to make sure they're not developing, they're lying on these hard mattresses 24 hours a day, make sure they're not developing blisters or breakdown in the feet. And then you also want to make sure, as best we can, to protect them from any incident, heart disease or kidney problems. Where do we manage them to? What's the right level? The study that everyone remembers is the Vandenberg study from, a long time ago, 20-something years ago, where they lowered blood sugars. You see the white was the control group, average blood sugar of about 150, and they lowered the experimental group down to about 100. And remarkably, again, 150 versus 100, and the mortality was reduced by 43%. Patients in the ICU, mortality was reduced by 50%. Bacteremia, blah, blah. This was great. Tight control in the hospital looked like it was important. The problem is that there have been a half a dozen studies afterwards, and nobody has been able to show it. So here's a study afterwards, about 5 years later, showing again 150 glucose versus 112. And here the goals are, you look at the outcomes, which is what the figure is. This is mortality. It's exactly the same. Okay? But there was an increase in hypoglycemia in the tight control group. So no benefit. Here's another one. Same thing, 144 versus 115, no benefit. So basically, there's been a lot of data that have been looked at. It turns out that people with higher blood sugar levels are probably sicker chronically or sicker in the hospital, and that's why they don't do well. But lowering their blood sugar to very low levels doesn't appear to benefit them. So there's been a real pendulum, loose control, tight control. The recommendations now pretty much are to be in the middle. So glucose levels in the hospital, 140 to 180 in the ICU and 100 to 180 in the non-ICU. It decreases hypoglycemia and it doesn't appear to have an adverse effect on their outcomes, okay? Special cases, we'll wind it up with special cases for inpatient. Metformin, we often hold it for fear of lactic acidosis, a rare complication, but one that can be deadly. So we often stop metformin and then restart it on the way out the door. Sulfonylureas, probably hold it because of the risk of hypoglycemia again, especially because their eating pattern has changed. They're missing meals, they're not eating the usual size meals, so we usually hold that. Insulin, we usually use that to treat people with type 2, type 1 of course, but type 2, and we have to adjust their medications to take into account their reduced POs and their altered eating. So this is where we keep an eagle eye on people. SGLT2 inhibitors, there is an increased risk for diabetic ketoacidosis. We always hold them in the hospital. GLP-1s, they're long-acting drugs. These are given, it used to be twice a day, some of you will remember, then once a day, liraglutide. Now it's once a week. And soon we'll probably be putting capsules in people. Soon it'll be in the drinking water, by the way, right? So everybody will be getting them. But the problems with them is that they decreases the rate of gastric emptying, leads to gastric atony. That's, by the way, what causes the weight loss. People are less hungry because their stomachs are just sitting there. They don't feel like eating because their stomach's still full from the prior meal. And that, of course, can lead to increased risks of aspiration, that kind of thing. So we have to be careful. All right, glucocorticoids. Just one quick note, glucocorticoids are often given in the hospital. If we're giving a glucocorticoid like prednisone in the morning, dexamethasone, not infrequently, especially for prednisone, the rate or the risk of hyperglycemia occurs in the same about 8 to 10 hours after it, and it matches beautifully the kinetics of NPH insulin. which some of you may not be using anymore. It's an intermediate acting insulin, and not infrequently, if someone's getting prednisone in the morning, we give them NPH in the morning to match the effect of the prednisone. All right, others. Usually, I mean, I don't know who's at home or who's here, but usually we have actually a fair number of psychiatrists who come to this course. And so they are well familiar with what, the atypical antipsychotics, especially olanzapine and clozapine, which we actually worked on the mechanisms a number of years ago. They result in weight gain, et cetera. But not infrequently, they will worsen glycemia. It's been shown in lots of studies. And you may need to change medications when you start people on these medications, which are, in fact, as the psychiatrists will tell us, quite effective. Everyone's on them, or a lot of people are on them. So you want to check your A1C carefully and then follow the blood sugar carefully. And insulin may be necessary in those. SARS-CoV, now maybe, knock on wood, if you know who allows us to have vaccinations and things. But hopefully we're over the epidemic. But when it was here, SARS-CoV in particular worsened glycemia substantially. People with diabetes, their glycemic levels rose dramatically. They often needed to be put on insulin. People who didn't have diabetes but were at risk, like much of the US population that's overweight or obese, they actually developed diabetes during the the COVID epidemic, okay? In addition, if they're giving steroids for inflammatory lung problems, that can worsen it. Oncologists, the checkpoint inhibitors affect T cell function, some of the T cell function that allows self-tolerance. And as a result, we see a number of autoimmune manifestations come forward. It turns out that it's, although we get called for it in the hospital, the risk of developing insulin-deficient diabetes is about 0.5 to 1% of people treated that way. Hypothyroidism, more common. Pituitary abnormalities, very rare. But a combination of other autoimmune manifestations. So that's another special case to think about. All right. So diabetes, especially type 2 diabetes, affects a huge fraction of the population. And as our population gets older, as we're looking at an older fraction of the population, it's even more common. Okay? Owing to its frequency and effects on virtually every aspect of clinical medicine, all of you need to be familiar with its prevention, diagnosis, and treatment, inpatient and outpatient. And as you may know, there are about 12 endocrinologists in the world. We can't do it all on our own, so we look to all of you for help in taking care of this population. Thank you.
Thank you so much, Dr. Nathan. What a wonderful talk. Lots of great data, anecdotes, and information for all of us. So I'm going to jump right to the questions. I'll start with a thoughtful one from a psychiatrist who's asking, well, we got a lot of folks, as you mentioned, on the antipsychotics, the olanzapine, et cetera. And what do you think about preemptively starting some of those folks when you initiate one of those medications with metformin, say a combination metforzapine or something like that?
Yeah, so it's an interesting idea, but I would say what I had on the slide, which I apologize for going through all of them fairly quickly, was that, in fact, I think it makes sense before you start anyone on one of these medications, get a hemoglobin A1C, okay? If it is in the clearly normal range, the chances that someone's going to develop a really major hyperglycemia is quite low. On the other hand, if their A1C, firstly, you may pick up people who have undiagnosed diabetes. They clearly need to be put on a medication. And then metformin would, as I said, certainly be the building block for that. For people whose A1Cs are normal, I think that watching them as opposed to starting a medication just because it's easy and cheap and we use it all the time, complicating their therapy by adding metformin when maybe they don't need it. But getting a glucose level periodically, like within weeks to a month of them starting the medication, often these problems emerge fairly quickly, I think would be the way to go. So I would not automatically or as a knee-jerk start them on metformin, but it's a good question.
Thank you. So what about ordering A1Cs in our older, frail patients? Say the 70-year-old or 80-year-old or wherever it may be. Sometimes when we order those, they often come back high, either in the diabetic or high pre-diabetic range. Should we do that? Is that do you recommend doing that?
Yeah, so the A1C, which I'm old enough that I grew up with the assay. I developed one of the very first assays for hemoglobin A1C. Gives us information that is just priceless, okay? Because all of the complications have been related to A1C level. So it makes the A1C a terrific therapeutic target because the proof is there. If you lower A1C, as I showed you early on in the talk, you lower complications. It is also a one-time stick as opposed to doing fasting glucoses and not knowing if they're really fasting, right? By the way, the majority of people, more than 50%, don't think that having coffee in the morning with creamer and sugar, that's still fasting, right? It doesn't really count. Of course I had my coffee. Are you kidding? But the A1C, it doesn't care. Whether you've eaten yesterday, today, 16 times in the morning, it is measuring chronic glycemia, which is why it's such a useful tool. So I think that the answer is it should be done routinely. It's recommended as a routine test, even in non-diabetics, on an annual basis, because it picks up diabetes easily. How many of you have done an oral glucose tolerance test in the last decade? Yeah, okay, probably obstetrics maybe, or pre-diabetes, or screening women for OGTTs used to be, everyone used to do them because it's a great test. It's a challenge test. It's a stress test. And it is quite sensitive at picking up abnormalities. I'm sorry to lose it because as an investigator, it gives you tons of information. But we don't do it. It's hardly done at all. In Canada, the last time an OGTT was done outside of pregnancy or a woman planning pregnancy was like never. I think they've prohibited it or something in Canada. But all of it is done with A1C. So I would argue that doing A1Cs is incredibly informative, easy to do. The cost of it is like $10. Medicare pays $10 or $11, I think, for doing an A1C. Easy to do. There are settings in which it's complicated. People who have had a transfusion, you're not measuring their A1C, you're measuring somebody else's A1C, or at least part of their blood is someone else's A1C. People who have had a recent anemia, it may be falsely low because their bone marrow is churning out new red blood cells that have not yet had the chance to be exposed to the glucose in the circulation, which is how A1C is formed, right? So anyway, I would say that it remains the backbone of diabetes surveillance, screening, et cetera.
Thank you. So for our patients who are currently on insulin, and we want to initiate either a GLP-1 or a combination GLP-1 GIP, what should we be thinking about? How should we do that? And particularly, how should we think about the insulin dosing?
Yeah, no, great question. So, again, if there are more on the insulin deficient, or type 2 diabetes is relatively insulin deficient, but some people with type 2, like about 10%, are very insulin deficient. They look more like type 1s. They're the ones that, based on the algorithm that you have in your handout, they're the ones that you're going to end up intensifying their insulin therapy because they don't make enough around meals. So you need to supplement them with a rapid-acting insulin. When you start a GLP, of course, the first thing that happens is that people get satiety. They stop eating as much, and therefore they don't need the usual insulin that they were taking. And that can lead, we want to avoid hypoglycemia at all. Most hypoglycemia is mild. They get a little uncomfortable. They get sweaty. They go, hey, something's up. I don't know what's going on. And you cut back their doses. But some hypoglycemia can be severe, lead to seizures, coma, death, car accidents, all that bad stuff. So you want to avoid that. That's a safety issue. And for that reason, when you start a GLP, you should certainly at least cut back insulin doses by 20% to start with. That's the safe thing to do. And I would probably do it pretty quickly. If they have type 2 diabetes, the reason that GLPs were developed was because they stimulate insulin secretion. So their own insulin secretion is going to go up. The second thing that happens within days is they stop eating as much. So that's the other reason that their insulin requirements are going to fall. So yes, the answer is that you have to adjust their insulin and follow it carefully.
Great, thank you for that tip. So for folks who we see getting CGMs, continuous glucose monitors, and who do not have diabetes, a lot of them will give us data or get data and be concerned maybe about their spikes, particularly postprandially. What do we make of all the non-diabetics, even non-pre-diabetics using this tool, and what would you make of it?
Yeah, so I've written fairly strongly about this, is that I think it's a waste of time. It is a way for the companies, firstly, CGM was developed for a tiny number of people, type 1 diabetes, 1.5 million people in this country, and they really need it. Their glucose levels fluctuate, they need to give themselves the right amount of insulin, and this provides them with minute-to-minute, day-to-day. Type 2 on insulin, pretty good data, it may help them as well as a safety thing. Everything beyond that is a money-making, you can quote me, it's unconscionable, I think, frankly, because it's costing us a fortune. And now RFK and our new Surgeon General, they actually have companies that are promoting this. I think it's a colossal waste of time. And I just think so it's a waste of your time, I think. They'll be looking at our blood sugars fluctuate. We eat episodically. Our blood sugars go up and down, okay? Duh. I don't know what you do with that information.
Thank you.
Was that clear?
I think that's quite clear. Thank you so much. So unfortunately, we're out of time. This has been wonderfully instructive. We greatly appreciate your time. I will tell the attendees both in person and virtually that we are having a special lunchtime movement activity led by a physical therapist, so I think you can get on board with that. Thank you. And again, really grateful for your answers, really grateful for your coming to this lecture, and thank you so much.